Hi, my name is Laura Quattro. I'm here today to do a case presentation on cystic fibrosis for Bob McMillan, APA 621. This case was taken from Edwards, Brenner, Isles, and Capure 2020. New case, recently published in February of 2020. This case presentation is of a 14-year-old female patient who neonatally was diagnosed with cystic fibrosis. Over the past 14 years of her early life, she's been positive for multiple MRSA infections and aspergillosis as well, all successfully treated. Recently, she presented to the ER with a productive cough and hemoptysis, as well as left-sided pleuritic posterior chest pain. Further exam, they decided to look at x-rays. The x-rays showed a cavitation of opacity in one of the lobes with an air fluid level, and they thought they'd look into that further, and they got a CT, and the CT was positive for a 5-centimeter abscess. Along with that x-ray, they also noted bronchoectasis in multiple lobes, quite chronic in nature. So as she had a fever and this productive cough, her O2 was completely normal. She was in very minimal distress. The lab work did show positive white count with neutrophils. She was C-reactive protein positive. All labs were with normal range and negative. After they did the CT and noticed that she had the 5-centimeter abscess, under ultrasound guidance, they drained the abscess, they cultured it, and it was positive for MRSA. They went ahead and started her on IV antibiotics for 10 days. After 10 days, they released her, and she completed a total of 4 weeks of antibiotics. I did find some information about MRSA that most people do a combination of rifampin and Bactrim, along with Bactroban ointment for the nose, and usually it is about 4 to 6 weeks of therapy. That was some additional information on Up to Date. Simon was the author in 2020. After 4 weeks of their rounds of antibiotics, they did not say what the home antibiotics were. That's why I did some investigation on my own. All her labs, CBC and CRP, were all within normal range. Where I thought this was important to discuss with the pandemic of COVID-19 and such lung destruction that it has on individuals, I felt that these patients were very vulnerable, and that this may be very important, and for us practitioners to be aware that even though we may not encounter a lot of cystic fibrosis patients, that they are very vulnerable, and we need to act quickly with these individuals, and we need to know what kind of bacteria that we're dealing with. One of the most common is Staph aureus. The second one is Pseudomonas, but on the rise. As of some literature in 2017, there was a huge jump from 2002 to 2017 of MRSA. So there's a lot more MRSA cases out here. Obviously, normal therapy to loosen and help with the treatment of cystic fibrosis and to eliminate the congestion that they have. Still with their therapies, they can have secondary infections, and they're on and off a lot of multiple antibiotics and antifungals. It's important that they remain consistent with their therapies. It's important that they remain consistent in their follow-ups with their physicians for 3 months sputum samples, and to basically continue therapy with their oral and inhalers, along with antibiotics as needed, their vaccinations to prevent any further infections that can ultimately affect their lungs, to act quickly to reduce their mortality, and to just be aware that there's more than just acerations of different conditions, that to look beyond so that we can identify and effectively treat. and to reduce as much long-term loss of function of their lungs as possible. Thank you and have a good evening.